70-year-old man with metastatic colon cancer is admitted to your service with a small bowel obstruction and is unable to tolerate oral medications. His long-acting pain medication at home is OxyContin 20 milligrams every 8 hours. He appears very uncomfortable and complains of severe abdominal pain. You want to transition him to intravenous hydromorphone to replace his long-acting opioid. How will you determine a safe and equivalent dose? Patients who are maintained on an opioid analgesic regimen frequently require a switch to other agents. Common reasons for this switch include a transition from short-acting agents to longer-acting agents for more predictable analgesia, intolerable side effects, changes in insurance coverage, the need for a higher potency agent, or a lack of availability of the oral route of administration. Equianalgesic conversions are used to standardize the dose of individual opioids based on their potency. Potency is the amount of drug required to produce a specific effect. When switching from one opioid agent to another, an equianalgesic conversion can be used to estimate the appropriate starting dose. An inappropriately low conversion can lead to withdrawal or poor pain control, while an inappropriately high conversion may lead to respiratory depression. Remember that these are guidelines. In many cases, these calculations were derived from single-dose studies. Additionally, individual opioid needs can vary based on tolerance and variations in drug metabolism. We recommend that you use your institutionally approved equianalgesic opioid conversion table, and we'll use the University of Massachusetts table for this example. There are many equianalgesic calculators and tables available online and in published formats. However, the calculators may not agree with your institutional standards, and the calculations are frequently not transparent. We encourage doing the math by hand. First, identify how much total opioid your patient usually receives daily. It is essential that you identify the route of administration as well, since different routes have varying potencies. This is simpler with oxycodone, which is only available orally. If the patient was taking 20 milligrams of OxyContin every 8 hours, he was receiving 60 milligrams of oxycodone daily orally. Second, identify the opioid that you will be transitioning to and make sure to correctly identify its route of administration. You will be transitioning to hydromorphone IV. Third, use your equianalgesic table to make the conversion. Using the UMass table, every 20 milligrams of oxycodone is equivalent to 1.5 milligrams of intravenous hydromorphone. So his 60 milligrams of oxycodone would be equivalent to 4.5 milligrams of intravenous hydromorphone daily. Fourth, you will need to consider a dose adjustment for incomplete cross-tolerance. In a case where the pain control is poor, the dose does not need to be reduced. In essence, a reduction of 0%. For our patient who is having pain control issues, we will administer the entire 4.5 milligrams of intravenous hydromorphone daily. Finally, you will need to evenly distribute the doses throughout the day to mimic the patient's long-acting medication. In this case, the patient could either receive a continuous infusion of 0.2 milligrams per hour of intravenous hydromorphone, or alternatively, a bolus of 0.75 milligrams of intravenous hydromorphone every 4 hours to mimic their long-acting opioid. For patients with complex pain management, we recommend discussion with the pain or palliative care consultation services. There are special considerations with conversions to methadone, and conversions to methadone should be discussed with palliative care to minimize the risk of respiratory depression or other adverse events. Share this video with your team and help make sure that everyone knows how to use an equianalgesic calculator.